Hi, Chris Mustard here, and I'm going to take us through a hypertension series, starting with malignant hypertension in this video, and I'll be following that up in succession with hypertensive emergencies. Both these first two conditions are relatively uncommon, but their principles are quite important in confidently managing hypertensive urgencies, which you'll see a lot of on the wards. So this is a useful set of videos to get under the belt. I'm going to go to the cerebral perfusion pressure curve, and in particular what we've got here is an autoregulation curve. And what does autoregulation mean again in terms of basic sciences? Basic sciences dictates that it's the physiological mechanism of maintaining stable perfusion pressure despite varying systemic arterial pressures and cerebral blood flow. If the pressure gets too low, the vasculature can't compensate for that anymore, and ischemia becomes a problem. Less commonly, we do not think about when the pressure's too high. So even in the brain, the vascular bed cannot protect it the whole time. And if the blood pressure becomes too high, you get passive dilatation and you have problems like cerebral edema developing. Right, so with that in mind, let's go on to malignant hypertension. This is defined as a severely elevated blood pressure, which can mean anything, but often the values are around 220 over 130. The more important hallmark is that there is end organ damage that includes items like cerebral edema, heart failure, potential chest pain due to myocardial ischemia, and acute kidney injury. When you request for a peripheral smear on hematology special investigations, you'll see schistocytes in some patients. Renal elements of this condition include acute kidney injury associated with proteinuria and hematuria. On fundoscopy, you'll see grade 3 and 4 hypertensive changes, and this refers to exudates, retinal hemorrhages, and retinal edema or papilledema. You can find LVH on ECG, although this is only an indication of a patient with chronic hypertension that has malignant hypertension. You can most certainly develop malignant hypertension, so to speak, out of the blue. So causes and precipitants, so this could be in medication non-compliance in a hypertensive patient. Also, it could be the use of sympathomimetics. In other words, this is my first patient I encountered with this condition on my first on-call for medicine as a registrar. The patient came in, he was in his mid-20s, did not have any blood pressure issues beforehand, had developed flu, and I was starting to take Sudafed, and he developed an astonishing pressure of 240 over 140, had frank heart failure, AKI, plus hematuria and proteinuria, although we termed AKI then as acute renal failure. He responded well to intravenous therapy and actually went home within a couple of days. The other common scenarios when medications are potentially tapered down, this could happen, and amphetamines. I think probably useful to in the emergency department, cocaine can also trigger malignant hypertension. Right, so here's a journal which I think is useful to quote, and I'll also send you a link below for this. So this is a RSCP Internal Medicine Journal of 2017. So yes, it most certainly happens in Australia. It gets published in Australia. So what you can see here is histology of the pathology of this condition of the kidney. So it does have glomerular effects. So think about the proteinuria. It also has blood vessel effects. So think about hematuria. So why the hematuria? First of all, this is actually quite an interesting slide here. And they actually don't, I think, make particular mention about the following, but that you in actual fact have a blood vessel wall that is thickened to that dimension. But if you look at the appearance, it looks like an onion that's being peeled. And so it looks like an onion skin appearance or onion wall. And that is the thickening of the arterial bed wall. So this is actually quite interesting. Now within that, you can then develop thrombosis and vessel lumen narrowing. And this all causes the bed to be a problem for the red blood cell to transverse, and you have fragmentation of the red blood cells, or so-called schistocytes. So you can see why you'd have AKI, glomerular pathology, proteinuria, and vessel pathology, having then your hematuria and schistocytes on the peripheral smear. Right, so that's just that in a bit more detail, and let's see if you can see that sort of onion kind of appearance there. Right, so let's have a quick case history to sort of wrap this all up. So you've got a patient, 55 years of age, and he comes into the emergency department. He's got blurred vision for a week, and he's got headache. He's got no chest pain, ischemia, no shortness of breath, failure of the ventricle, or confusion. Right, so blood pressure is 250 over 170. Okay, now your mind should be going, right, this is probably hypertensive emergency, maybe even malignant hypertension. So let's see. Do we find features of acute kidney injury here? Yes, there is. And there is also hematuria and proteinuria. So on the physical examination, you look into the eyes and you find this. Right, so this is what you're looking for. So you can see clear papilledema, you can see hemorrhages there, and you can see exudates there. So all of this is classical malignant hypertension. And you may actually identify this journal. You may have seen it before, right? So is this still relevant? Yes, it's a 2021 publication. So yes, this definitely helps, but I think the more important part is it builds a good foundation as to looking at hypertensive emergencies in the next YouTube video in the next week or two. Right, so treatment for this is the blood pressure needs to be brought down rapidly. We'll discuss that in hypertensive emergencies. You use parenteral agents, in other words, intravenous medications, beta blockers, and we'll discuss all of this in hypertensive emergencies. And then you've got good context as to how to go about hypertensive urgencies in that this will be your bread and butter thing. This is the thing you're going to commonly encounter, but you first want to exclude these other two conditions. So not to be too confusing, malignant hypertension is in actual fact a subtype of hypertensive emergencies. Then I think later on, which will be useful to wrap up this series, will be what do you do when someone asks you to do a secondary hypertension workup, and what do you do with uncontrolled hypertension management on the wards, right? So I hope to see you soon again, and take care.